Good afternoon, everyone. I would request everyone to just get up on your toes, top of toes. Let us feel our foot, the ground. Thank you. Uh, I would like to thank Dr. Pavan, Dr. Sanjay, and Ergo team just giving me opportunity to be a part of an Podocon. So, I am going to discuss about the winning protocol with an innovative technology in diabetic foot ulcer management. So, the continuation of an management of the wounds, I am going to discuss. If you just see, while just talking about the wound care, wound bed preparation is a paradigm for the patient's wound care. We have to identify and treat the cause and review the patient-centric concern, comorbidities and cofactors. Identify the patient-centric concern, pain, cost, and at the same time also the activity levels. Determine the ability to heal. Is the wound healable, maintenance or non-healable? Plan for the local wound care. If the perfusion is adequate, go for the debridement. But we have to take care of an inflammation as well as a local infection. And if the wound, keep the wound moist, so that will also encourage the healing. If you find wound having an edge effect, go for an biopsy. Biopsy shows negative, that means you can plan for adjunctive therapies. So this was a wound bed paradigm which we have published in 2021 with my mentor Gary Sibyl, Professor Gary Sibyl, James Elliott, and Dr. Armstrong was one of the co-author with this. So today we are going to talk about the inflammation and local infection. That leads to a delay in the wounds. So earlier we were just seeing the adherence. This is the other factor also that can lead to a delay in the wounds. So on the healable, where the underlying cause can be corrected. So perfusion is adequate, so we can correct the cause. Maintenance, where the underlying cause can be corrected, but the adherence to the system or lack of system resources. For example, the patient having non-healing ulcer on the plantar aspect of the foot, that is not healing due to the offloading. He is not adhering to the offloading. So it leads to a maintenance wound. If we correct the offloading, that wound is going to heal. Then third part is in non-healable wounds, where underlying cause cannot be corrected. Maybe a negative protein balance or terminal cancers. We can prevent from the infection and take patient-centric into concern. For example, pain, smell, that at least he can live his life very well. As already discussing chronic or non-healing wounds, which will not show the healing signs within the 6 weeks or 20 to 40% wound reduction within the 4 weeks. So what would be the key factor in making the dressing decision while just dealing with this infected or inflammatory wounds? So you need a dressing that have gotten that will fight against the local infection, requires an antimicrobial activity and complete continuous cleaning action of the wound. Then both the factors will help in the wound healing. So you just see Ergo Clean AG have got both these components that help in the wound healing. For this purpose, we are going to now in the case series, that will make evident how that Ergo Clean AG is effective at the both components. This is the case 1, Mr. A, age 70 years of male, business, was by occupation he was businessman, type 2 diabetic since 2010 with an hypertension, CAD, previous history of ulceration and amputation, that means his foot is at high risk. He was anxious that he's going to lose his limb, and he was not having a fear of death, he was having a fear of losing his limb. It was presented with a non-healing wound, 4-foot plantar aspect from last 1 year. Probing to bone test was positive, that means osteomyelitis. Neuropathy was positive, pulses were present. Then we checked it with a handheld Doppler, the pulses were biphasic as well as triphasic. The infection was present. For pressure redistribution, he was not using any offloading device. Post debridement, we put him on the modified total contact cast. He was taken for the surgical debridement. So if you just see the patient having an 3 or more Stoney's criteria, that means S means size increase, temperature increase, probing to bone test was positive, exudate was present. So we treated it systemically as well as local wound care. For local wound care, we treated with ErgoClean AG, having in both effect as an antimicrobial as well as complete continuous cleaning action on the wound that will lead to a proper wound healing. You can just see the series of photos, how it started from first week, goes up to 18 weeks. And the same thing can be observed in this wound healing trajectories, that how it has helped the progression of wound healing, and you monitor the healing of the patients with the time. If it is not showing the healing pattern, you can reassess the patient. You can't go directly just putting on whatever you have got and on the wounds and it starts just working, and maybe it will land up you to 3, 4, 5 months, 6 months and coming up with no results. So wound healing trajectory helped to us at what time we have to reassess the patients. And you can just see we are using the ErgoClean AG, and this was helped the patient to get rid from the non-healing wound. To the audience, what is most likely diagnosis? Is it pyoderma gangrenosa, venous stasis, infection, skin cancer, or lymphedema? What do you think about this? So you can just go with the cases, you may just come to know. This is a second case, Mr. D, age 45 years, male, farmer, having a pre-diabetes, CAD, history of blood injury, traumatic AV malformation, AV fistula with venous ulcer. He was underwent an surgical intervention, dismantling and ligation of a AV fistula with an sclerotherapy of an vena comitans, also called the satellite veins. So already gone for that. His anxiety level was high because he was thinking that this wound is going to with him for a lifelong, and then pain score was 8 out of 10. In the diabetic neuropathic wound, you can't find the pain, but here in the venous leg ulcers, definitely they are just painful. So it was non-healing from last 17 years. So right leg medial aspect and hyperpigmentation of the skin. Neuropathy was negative, he was showing the biphasic flow, and infection was present, but it was a local. He was using 4-layer compression bandaging for on and off, but he was not able to tolerate that. Maybe because of the mixed etiology, like having an arteriovenous insufficiencies. So we put him on the 2-layer compression bandaging. At the surgical intervention, already he was having it at other center. So having a NERDS criteria, non-healing, exudate, red, bleeding, with a smell present, we used ErgoClean AG. At the same time, having a continuous cleaning action and at the same time antimicrobial action. So you can just see the series of patients. When we see the photographs till 10 weeks, the wound starts healing. The wound which was non-healing from last 17 years. So we treated the underlying cause. It is not only the dressing, it's the dressing with the combination of a standard wound care. That means the compression 2-layer, because he was put it on and off with a 4-layer band compression, which was not tolerable. So patient-centric concern should be taken into consideration. So if you just see Here you can just see there is it is saturated with an ErgoClean AG, is saturated with an exudate. People think it is an pus coming out there or some, but it is basically, it is beauty that it removes the debris, slough, and at the same time exudate out of that and creates a moist environment over the wound, so takes care of the moist healing at the same time. You can just see by graphical representation the progression of the wound healing trajectory, and you can just see the same patient, no hyperpigmentation, and wound get resolved. At the same time, you can just, we put him on the this compression stockings post of that of class 2. This is the same case, having a non-healing wound 17 years from the lateral malleolar side, and it was also having a same NERDS criteria. You can just see series of photographs of the same patient. We get this healed within the 10 weeks, and you just see there was no hyperpigmentation and the wound get closed. So what happened with the wounds that are infected? Actually, when the wounds get infected, there is a vicious cycle that causes a damage and delaying in the healing. They are the interlinked. The symptoms often, if you just see the symptoms of a wound healing, there is interrelation between the factors. Like when there is an increase in exudate, there will be a decrease in the wound healing, that by sustaining the biofilm and microbial dissemination. Microbes get disseminated. Slough and debris, that favors the microbial proliferation, and that proliferation lead to a biofilm formation. And when the slough is there, wound debris is there, that helps the bacteria to get multiplication, to multiply. When they multiply, they lead in layer over the wound bed that we call the biofilm. So that biofilm limits the action of silver dressings. So we need the dressing that will take care of both, as well as an antimicrobial activity. At the same time, remove the slough, remove the debris, and take out the exudate from the wound. So ErgoClean AG was the better innovative technology for the these type of infected, inflammation wounds to take care. If you just see, the two exclusive technology offers antimicrobial property and complete continuous cleaning action. First, one layer, you can just see the TLC AG healing matrix have got an antimicrobial activity. That silver ions released just kills the, having a broad spectrum antimicrobial activity or efficacy, and at the same time polyabsorbent. You can just see with the, I think that video is working. So you can just see the release of silver that penetrates through the biofilm, at the same time also having an antimicrobial efficacy. And the polyabsorbent second layer on the top is the polyabsorbent fibers that shows the complete continuous cleaning which I was talking. It have got fibers that trap the debris, exudate and slough out from the wound, keep the wound clean. So by combination of an cleaning, antimicrobial efficacy, that defeats the biofilm and prevents the reattachment of the biofilm and the microbial load. But I was talking to Ergo people, why you are just keeping only two factors, like two exclusive technology. If you go back to the wound bed paradigm, there is a debridement, there is a second phase is a control of infection and inflammation, third is the moisture balance. That is the key factor here, that it takes the antimicrobial action and removes the slough and debris and keeps the wound clean. Third, it also keeps the moist wound. So it have got a triple action over there in place of double action. So you can just see there are the two layers. One layer at the bottom have got a TLC technology. Silver sulfate is impregnated in that layer at the lower layer. You can just have a look over the stall. They have gotten this dressings over there. they have got a lower layer that is having a silver impregnated in it. It is slowly released, and that have got an antimicrobial activity. And the top part is in polyabsorbent fibers that help to continuous cleaning and remove the exudate from the wound and help in the wound healing. So, but always whenever we just use any dressing or any type of new device, so in my personal practice, and everyone should do that, use more often having an evidences. I believe on more data, not on a charta. So that is the key here. When we gotten this ErgoClean AG evidences, you can just see it have got from an in vitro studies that is showing the antimicrobial activities at the biofilm level. It has case series also showing it is covering 40 strains around often bacterial strains around 36 and 4 yeast antifungal activity also it have got. So another factor is it is showing the more efficacious penetration to the MRSA and P. organosa, Pseudomonas organosa, because as compared to Aquacell AG+. These are the evidence already, and randomized control shows the disulfing property 50% more as compared to the Aquacell within 6 weeks, and it is efficacious against the inflammation and against the infection. This how it can be used. It's an example how it can be used also cut in and cavity for the cavities according to the wound structure or in between the toes. Previously Sanjay Sharma was showing that how he was putting inside the toes when the wounds. So you can just manage it accordingly the structure of wound or the cavity where you want to put it. Now here comes the case 3, Mrs. B, age 56, female, housewife, known case of type 2 diabetes, since 14 years, hypertensive, having a non-alcoholic fatty liver disease, severe anxiety because of the pain. She was not able to put her foot on the ground. Neuropathy was present, pedal process present, triphasic flow. She was having a Stoney's criteria. Peak plantar pressure redistribution, she was not using any peak plantar pressure redistribution device. So we put her on a posterior slab with padding, post debridement. You can just, she was having an 4 out of 7 Stoney's criteria, more than 3 Stoney's criteria, size increase, temperature increase, exudate, erythema or edema. We just treated it within systemically as well as local wound care. Here for local wound care, we used ErgoClean AG followed by the ErgoStart. Now you can just see the series of photographs. Here post debridement, you see the inflammation and infection over there. When we treated with ErgoClean AG for 2nd week, 4th week till 5th week, you just see the infection and inflammation starts going down. And at the 6th week, there were some cavities or dead spaces. We put in biocomposite material that carries the antibiotic along with that. So antimicrobial, antibacterial activity it have got, and we put it over that and then use the ErgoStart for the continuous care till 8 weeks, and then after that we put in dermal template over it, and you can just see within the 9 weeks, after 9 weeks, the wound get closed, and you can just see the progressive of an wound healing trajectory also at the same time. So this shows the continuity of care from ErgoClean AG for infection and continuous cleaning, and then maintaining within ErgoStart. Another case, post forefoot amputation, having a granulation, red granulation, but sometimes beefy red granulation is not good. That is in biofilm is present. You can just see the satellite areas. This pedal pulses were present. Monophasic, he was having a PAD. Stoney's criteria were present. That means is infected. He was using a wheelchair and assistive device. Post forefoot amputation, he was having an Stoney's criteria, means size increase, temperature, new breakdowns, exudate and erythema, which was taken care by the ErgoClean AG and ErgoStart followed start followed by. You can just see this series of pictures, and there was dead space. You can just see also the new satellite areas where we put it the same matrix stimulant or biocomposite having an integrated into this space, dead space. And but 7th week I found that it is getting saturated or macerated over the wound. We started using a ergo start, and you can just see 12th week the wound get totally healed. Here I have just put one picture to show you, if you use sometimes ergo clean AG, you might find some pus like exudate coming out from the wound. That doesn't mean this is a pus. This is the, I was just saying the beauty of this product. It do the autolytic debridement. I can do this, taking out the slough debris out from the wound and do the best wound healing over that. So what is ergostat basically? You just see TLC NOSF technology. TLC is a technology of lipid collider. So of a discrete hydrocollider particles having an dispersed in the jellified manner. And NOSF acts as an acts against the MMPs. As Srinivasan was saying, matrix metalloproteinase. In normal wound healing, we have got matrix metalloproteins in every stage. So that is important for the wound healing because it takes away from the extracellular matrix and non-viable tissue from the wound. But when it goes over, means excess, maybe underlying cause, diabetes, maybe insufficiency of venous or insufficiency of arteries. So that may lead an MMPs to get raised. So we have to decrease that MMPs with that ergostat. Already Srinivasan has talked about how it has just taking away MMPs and at the same time closes wound earlier. So evidences were present. You can get it in different ergostat border, which is having a silicone backing, superabsorbent layer, and TLC NOSF healing matrix, which helps take MMPs, and it is highly absorption. Then ergostat, it is also having the same effect, but it have got no silicone border. I am just finishing out ergostat contact. It is a flexible and conformable, and it can have got the same activity. Ergostat already, I think that Dr. Srinivasan has already spoken about the evidences. So I think that we were able to evaluate the wound bed preparation, assess and treat the diabetic foot ulcer and venous leg ulcer wound cases with Ergo Clean AG followed by ergostat, mechanism of action of an Ergo Clean AG and ergostat, and we have reviewed all the highest level of evidences with both of these products. So these are the products of the choice with a data, not a charta. Thank you.